Hello, welcome to the Spring 2022 Parkinson's Patient Symposium here at the University of Iowa Parkinson's Foundation Center of Excellence. I'm Kara Iyengar, the Center of Excellence Coordinator. First, a few housekeeping items. This program is run in a webinar format, which means only the speakers will be shown on the screen. Closed captioning is available for this program. If you would like to use captions, click the CC closed captioning button at the bottom of the screen to start viewing closed captions. If you experience technical difficulties during this program, please email me, Kara Iyengar, at kara-iyengar@uiowa.edu. That's CARA-IYENGAR@uiowa.edu. Please leave your callback number in the email message. You will receive a post-event email with links to the videos shared today and other resources that are mentioned. This will be sent to you after today's program. You will also be directed to a post-event survey immediately upon closing of this webinar. Please take a few minutes to complete this survey. Your feedback is important to us and will help us improve future programs that are hosted on this topic. Thank you for joining us today. Now I'll turn it over to Dr. Uch to continue our introduction. Thank you.
Hello, my name is Ergun Uch. I'm a professor of neurology at the University of Iowa Hospitals and Clinics and the director of the Parkinson's Foundation Center of Excellence at the University of Iowa. I'm also the site director of the National VA-PD Consortium Center at the Iowa City VA Hospital. Now, I would like to introduce our center in more detail. Our hospital is across the main campus, west of the Iowa River, together with the law school. Right across our hospital, we have the Kinnick Stadium and also the VA hospital. We see annually more than 1,000 patients with Parkinson's disease at the University Hospital and more than 500 patients at the VA hospital. University of Iowa Hospitals and Clinics has been considered one of the best large employers in the nation. And we do extensive research funded by NIH, VA, Department of Defense, Parkinson's Foundation, Michael J. Fox Foundation, and also National Science Foundation. We have many collaborators across campus, including the UI National Advanced Driving Simulator. And since 2018, we have been part of the Center of Excellence network of Parkinson's Foundation. We share this honor with about 30 plus centers in the US and 10 plus centers across the world. And we arranged the first national meeting on Parkinson's disease together with Parkinson's Foundation in 2019. These are the providers, the physicians and our nurse practitioner at the Movement Disorders Division. You may have seen one of us. And also we work very esteemed colleagues from different disciplines at the hospital, in particular, Dr. Greenlee from neurosurgery, our very talented DBS neurosurgeon, Dr. Duffy from psychiatry. And also without the help of Kara, who holds all of these different functions together, we wouldn't be able to function. Lisa Proschel and Margaret Gassman are key pillars to our operation, and our other colleagues include Dr. Anderson and others from neuropsychology, Stephanie Evans and other therapists from PT, and Rachel Rose and other therapists from occupational therapy. We also refer to other colleagues in different departments as needed. Thank you. I would like to talk today to you about the effects of cognitive impairment on daily lives of patients with Parkinson's disease. I do not have any conflicts of interest, but have received federal funding from VA, NIH, and Department of Defense, as well as private funding from Michael J. Fox and Parkinson's Foundation, and Cedar Family and other philanthropists for funding of my research. I will start with a case study. 57-year-old construction contractor developed a right thumb tremor at rest and shoulder pain and stiffness. He also started to act out his dreams and hit his wife unintentionally during his sleep. He was diagnosed with Parkinson's disease 2 years later. Over the next few years, tremor and stiffness responded well to carbidopa-levodopa therapy, but he developed problems with planning projects, coordinating subcontractors, and managing his finances. He retired at age 64, which strained his family's finances. He became more anxious and irritable, affecting his relationships with family and friends, and he lost interest in his hobbies. He stopped driving at night at age 67. After getting lost in his hometown and a fender bender, he completely quit driving at age 69. He started to have falls and needed a walker in his mid-70s, and he developed hallucinations and dementia. He started to choke on his food. This is unfortunately a typical course of a patient with Parkinson's disease. First, a quick overview of what Parkinson's disease does to the brain. It affects multiple pathways and causes reductions in different brain chemicals, such as dopamine, serotonin, norepinephrine, and acetylcholine, which are important for motor function, cognition, mood, autonomic function, controlling the inner organs, and also cognition. Parkinson's disease is known for its motor problems, such as slowness, stiffness, resting tremor, and it's diagnosed when these problems become manifest. And treatment, such as dopaminergic medications and DBS, are also directed against that. However, during the course of the illness, the effect of these medications, and if they had DBS, diminishes over time. And patients develop postural instability and gait disorder and freezing of gait that are not responsive to these measures anymore. And they may develop falls and swallowing difficulty and choking. At this stage, it's very important to engage physical therapy, occupational therapy, speech therapy, and palliative care, even though these disciplines also have a role in earlier phases of Parkinson's disease as well. Even though Parkinson's is diagnosed only after the motor symptoms are evident, actually the disease has 10 years or longer period during which it is developing in the brain and causing some symptoms. We call this period premotor period or prodromal period. During this period, patients may have manifestations like constipation, loss of sense of smell, stomach motility problems, bladder urgency, and eventually also develop orthostasis with dropping of blood pressure upon standing and even passing out because of that. Also, before diagnosis, patients may have sleep disorders, especially REM sleep behavior disorder, like the case study I mentioned. They may start acting out their dreams and even be dangerous for their bed partners. They also develop insomnia and excessive daytime sleepiness over time. Depression and anxiety can also be present even before diagnosis, but also occur after diagnosis. And also patients with PD may develop apathy, which is loss of interest in hobbies and other things they like, even though they may not be depressed. Hand in hand with cognitive impairment, patients develop hallucinations, seeing things which are not there, which may eventually progress to even worse forms of it with fixed false beliefs called psychosis. Mild cognitive impairment can be a manifestation from the very beginning, with 20% of patients showing mild cognitive impairment even at the time of diagnosis. More than 50% of patients develop it. In terms of dementia, if people live long enough with the disease, such as more than 20 years, and get old enough, like late 70s, early 80s, or higher, then more than 80% of patients also develop dementia. All these features cause problems with employment, social life, and driving. When we review the root causes of employment problems, poor social function, or driving, we see that the cognitive symptoms are the most important predictors of these problems, even more than motor and psychiatric issues, even though they're also important. Cognition, or mental function, consists of different areas or domains. In particular, in Parkinson's disease, executive functions, attention, visuospatial perception are affected early, and memory and language come later. Executive functions are those functions that include planning, decision-making, judgment, flexibility, multitasking. We can screen for cognitive dysfunction in the clinic using short tests like MoCA. However, proper diagnosis requires testing on another day called neuropsychological testing, which may take 2 to 4 hours by specialists. Parkinson certainly increases the risk of early retirement, even early in the disease. Soon after diagnosis, within the first 3 years, the risk of retiring early is twice as much as their peers without Parkinson's. And that risk increases to 5 times once they start using a cane or a walker. Parkinson also affects lifetime earnings. Somebody who's diagnosed at age 40 may be losing 40% of lifetime earnings at 55, 20%. How can we prevent early retirement in PD? One thing, of course, is to optimize Parkinson treatment to prevent off periods, especially during work hours, and treat depression and anxiety. Also, hopefully, the workplace will be accommodating with modification of schedule and type of work, more time for tasks with extra breaks and supportive supervisor, and availability of vocational rehab support if a different line of work is needed. Because of the changes in emotional processing and reduced nonverbal communication, such as decreased gesturing and mimics, patients have disruptions in social functioning. Certainly, from being equal partners to becoming a care receiver also changes the social dynamics. Impaired daily activities, such as getting dressed, walking, can also decrease social activities. As a result of these changes, patients with Parkinson's disease score poorly on quality of life items such as communication, stigmatization, and social support. These problems are more pronounced if the disease starts earlier, which leads to bigger problems in marital and family life and financial strain. To mitigate the social and family complications of Parkinson's disease, of course, again, the treatment of disease is important with motor and cognitive symptoms, treatment of depression, anxiety, autonomic dysfunction, including sexual dysfunction is important. Also, going to therapists as needed, developing strong coping skills, family support, and planning ahead for crises are critical. As needed, multidisciplinary rehabilitation with PT, OT, speech, and cognitive rehab should be employed. Arts-based programs may help with coping skills, and palliative care at any stage should be employed. Employing these types of programs and multidisciplinary approach also reduces caregiver strain. Moving on to driving in Parkinson's disease, because of all these visual, cognitive, motor, and executive dysfunction, patients with Parkinson's do more safety errors on driving tests in the simulator and on the road. But we observed that at their baseline testing, 25% of our PD participants were driving normally, like their peers. However, we also observed that they declined a lot more over 2 years compared to controls, and their driving was made a lot worse than controls when they engaged in multitasking. The biggest predictors of driving impairment were vision and cognition impairments rather than motor dysfunction. We also observed that many of our Parkinson patients stopped driving earlier than their peers without Parkinson's. And this might explain why there is not an obvious increase in crash rates in Parkinson's. Probably people who would be crashing quit before that, hopefully. Now I will show a few experiments from our research in driving simulator where there is no life or limb at stake, and you can adjust the simulator settings easily. We observed that even in high visibility setting, patients with Parkinson's had more weaving and lane violations compared to controls. But when we switched them to low visibility in the same road segment later, we saw that they had a lot more weaving and lane violations. So such challenges like inclement weather have a lot more effect on patients with Parkinson's disease than controls. Also, this is another challenging experiment in the driving simulator. Our patient is driving driver A, approaching an unprotected intersection where the driver B will be jumping in front of him without warning. And let's see how a control and two Parkinson patients react. So this is a control. We made the environment foggy to make it more challenging. He's driving pretty straight at 40 miles per hour or so, and he sees the threat and stops timely. Whereas this Parkinson patient, already weaving, not very safe, driving at 53 miles per hour, reacts too little too late and slams into the vehicle. This particular gentleman actually did even worse. So he was weaving badly even before anything happened. And when the vehicle emerged, he slammed into the other car without changing his speed at all. So the crashes were a lot more frequent in the PD group, and the reaction times were a lot longer. We also tested them in and around Iowa City on the road in a special instrumented vehicle with various sensors and cameras. It was a 20-mile drive over 40 minutes or so. And in this particular experiment, we are asking the patient to add up numbers spoken to him in succession. And we will observe how badly his driving deteriorates on 218. So he's driving straight and at 60 miles per hour first. And when he starts doing the task, he starts weaving. He will violate the lane a few times like here. And also his speed keeps dropping to unsafe levels. So his driving becomes a lot more erratic. So another example of how distraction has a lot more negative effect in Parkinson's disease. So for patients with PD to drive safer, please be aware of your limitations, but also know that PD can impair your insight and judgment. So it's important to listen to your caregivers and healthcare providers if they are concerned. You may need to undergo cognitive driving test if necessary, and after a certain point, probably need to undergo annual driving tests. Avoid driving at night in inclement weather in unfamiliar locations because these stresses increase the risk of errors and crashes. Also avoid busy intersections and unprotected left turns, as common sense and our research has shown. Also avoid distractions such as phone, conversation with passengers, listening to emotionally charged radio, eating, and always keep your eyes on the road. Now, treatments for cognitive impairment. The treatments we use for Parkinson's, like levodopa, other medications, DBS, they have motor function, but they may actually have some cognitive side effects, so they don't have cognition much. The main medications we use are the medications we use for Alzheimer's disease, such as rivastigmine, donepezil, memantine. Unfortunately, there is no proven drug for mild cognitive impairment. It's very important to treat coexisting problems such as insomnia, depression, and psychosis, which can in turn improve cognitive function. Also, there are data on non-pharmaceutical strategies, non-drug strategies, but these are not proven. So physical exercise, cognitive training, or rehab are promising, but again, not proven. So another example of PD course, this is my patient. He was diagnosed at age 48, and younger patients usually function better for a longer time. He had DBS at age 62. At age 67, almost 20 years into his illness, he was very functional, playing golf, driving, and he had little shrinkage in the frontal parts of the brain. So here we see the DBS wires. At age 75, even though there wasn't much change in his DBS or medication and the same doctor, he became unable to walk, got demented, could not speak. And why? Despite all the same treatment, because the disease continues to progress, the disease keeps eating up at the brain because it's a degenerative illness. And you see that there is a lot of loss in the brain tissue. So is there any way to prevent that? Unfortunately, clinical drug trials so far have not proven useful, but there is still hope. One potential strategy could be exercise. Does exercise promote better brain health? There are some indirect evidence. There's some indirect evidence through animal studies. And human studies are not certain yet. But still, it's useful to engage in exercise, most likely involving many different components, such as aerobic, strength training, balance, agility training, and stretching. So having a balanced exercise regimen is probably helpful, even though we do not have clear guidelines yet. So among these exercise modalities, aerobic exercise has been the most studied. We have reasonably good evidence that it improves physical fitness in PD, and also probably the Parkinson scores. The jury is still quite out if it changes posture and gait, quality of life, and other non-motor symptoms such as cognition, and there is really no proof if it changes the disease course. Of course, if compliance is poor, no results will be obtained, but also one has to be very careful not to overdo it, because falling can result in fractures. Doing very strenuous exercise without good preparation or good cardiovascular health can result in heart attacks or similar problems. So what are the unresolved issues in exercise in Parkinson's disease? So maintaining physical and mental activity and social engagement is certainly useful for general health and probably cognition. However, no well-established guidelines for PD yet, because current research has been mostly of low quality with small patient numbers and short duration of intervention. So therefore, we don't have a clear modality, dose, and duration available for you as a cookbook regimen. And we don't exactly know if any benefits from exercise transfer to real life, if they affect real life functions such as cognition, ability to work longer, drive safer. And also we don't know if they generalize to all patients with Parkinson's disease and if they have long-term effects. These are all parts of research. So I would say until various details are worked out, please work with your care providers such as physical therapists, neurologists, primary care, for customized programs which are safe for you. The important thing is safety first. I would like to touch on our past and current research on aerobic exercise in Parkinson's disease. With a grant from the VA, I did a 3-year study between 2009 and 12, and it was published in 2014, showing that brisk walking can improve Parkinson features, some elements of cognition and mood in Parkinson's. It gained quite a bit of global and national traction in the media, even in Chinese newspapers. However, it was still one of the short and small studies, despite the promising results. So I have a new study funded by the VA, but open to general public, done at the University of Iowa hospitals and clinics. In that study, we are comparing brisk aerobic exercise to health education and see if 1 year long aerobic exercise improves Parkinson's brain health as measured by MRI techniques, and if it also improves driving as a real life function using similar techniques like in my previous research. This study is a 5-year study and will end in mid-June 2024. And patients who are living independently, still driving, not using a cane or walker, and who did not have DBS and who have good general health are good candidates for this study. So in summary, Parkinson's disease is a progressive degenerative disease that affects multiple brain regions and brain chemicals. It causes motor, cognitive, psychiatric, autonomic, and sleep symptoms. Parkinson leads to early retirement, driving impairment, and disruption in social and family life. and cognitive impairment is the most important contributor to these, followed by psychiatric and motor symptoms. Symptomatic treatment with medications and deep brain stimulation provides benefit for motor functions, but for a limited time. Treatment of non-motor manifestations is symptomatic and is not specific to PD. There is no proven treatment yet to prevent, halt, or alter the course of Parkinson's. However, physical exercise is promising, but more research is needed. Safety first. So thank you for listening to my talk, and I look forward to meeting you again during Q&A session at the symposium. Thank you.
Good morning. I'm Jeremy Greenlee. I'm one of the neurosurgery faculty here at the University of Iowa, and I'm pleased to speak to you today about how we use deep brain stimulation to help treat patients with Parkinson's disease. And I have no financial relationships with any of the DBS companies. I do receive grant support to conduct research from the federal government and specifically the National Institutes of Health. So surgery for Parkinson's disease is a increasingly common technique that we use to improve symptom control. This started out with observations in stroke patients that had lesions in the center part of the brain, and it was observed that their Parkinson's symptoms got better. This led to then intentionally creating lesions, or basically scars, within the brain. This is what a brain MRI looks like, and you can kind of see this little white cavity here. That's what a lesion can look like. So initially, the lesions were created with heat and radiofrequency lesions through a needle. We can also create lesions with a focused radiation machine, and we can also use focused ultrasound to create lesions that are basically irreversible, permanent scars in the brain to help control symptoms. So they can be a good option for some patients. Ultrasound has made a resurgence, actually, and it's useful for tremor. But typically, lesions can only be done in one side of the brain because of an increased risk of scar tissues. The alternative that's arisen from this history is actually deep brain stimulation. So in those same areas within the brain, we can place an electrode to use basically electrical impulses to modulate this brain tissue and these abnormal circuits that are affected by Parkinson's disease. So why would we consider DBS, or deep brain stimulation, to treat a Parkinson's patient? Well, the short answer is studies have shown that patients that have stimulation as well as medications function better and have better quality of life than patients that are just on medication alone. So specifically, the things that we look for and that we know that DBS reliably improves is, number one, motor function. Parkinson's is primarily a motor disease, but we'll talk about the other non-motor effects, and you'll hear some of that today from other speakers. But we know that DBS does improve motor function, specifically rigidity or stiffness or slowness, tremor, and sometimes patients, as they have to take escalating doses or higher doses of Parkinson's medications, the medications themselves can cause side effects, particularly dyskinesias. And this is the sensation where you can't sit still, and patients will kind of wiggle around. And that's a side effect when the medications kick in. So the studies have also shown that patients with DBS systems have more on time during the day, where you're functioning better compared to off or more rigid or more frozen times, as these drug effects or the medication effects fluctuate over the course of a day and over the course of a dose of medication. When the stimulator is turned on, oftentimes we are able to reduce how much Parkinson medication is required to manage symptoms, so that sometimes drug dosages can significantly be reduced when the stimulator is turned on. So to illustrate this point, this is kind of a cartoon schematic of what happens when we give a dose of the Parkinson medications like Sinemet or carbidopa, levodopa, or the dopamine medications that are most often used and most beneficial for patients. So at time 0 here, time is on the x-axis. Patient takes their medication and their motor function improves. So they kind of swing from the off time into the on time. So we want to have as much time during the day in this green on phase where your hands and limbs and legs are more fluid and easier to move and less stiff. And then as the medication wears off, then that function gets a little bit more problematic, and then we cycle back down into the off phase. So early in disease, not as much medication dosages is required. Medications last longer, and patients can do very well with just medication alone, and they would take another dose here to kind of try to keep this curve in the green phase. However, as the disease progresses over time, which unfortunately we know it's a neurodegenerative disease, so the symptoms do tend to get worse over time, then patients have to take an increasingly higher dose of medications. So then when the dose kicks in, sometimes with these high doses, we can get the side effects or the dyskinesias and have a very short time in the green phase on the way up, another time as some of the medications wear off in the green phase on the way down, and then kind of rapidly cycle from the red to the green to the dyskinetic state. And it becomes increasingly more challenging to manage and allow patients to function as best as they can. So DBS is very good at improving these motor fluctuations and also treating the dyskinesias themselves. So how do we identify a good candidate for deep brain stimulation? So it's a challenge sometimes, but the neurologist does most of this. And so by doing a detailed examination and a neurological examination to be sure that we have the right diagnosis of idiopathic Parkinson's disease and not other Parkinson-like syndromes, we want to be sure that we know that the most common form of Parkinson's disease is what we're treating, and that's the most responsive to the DBS. So in general, the stimulator is going to improve the same things that the medications improve, whereas the things that the symptoms that the medications don't tend to help tend to be less responsive to the stimulation or won't get better with the stimulation. So the easiest way to realize this, or for patients and doctors to see this, is to stop all Parkinson's medications for 12 hours and then do this on-off levodopa or Parkinson's medication test. So patients come in off of their medicines for 12 hours. The neurologist would examine them, give them a rating score, have the patient then take their medications, and then give another rating score when the medications kick in. And we like for patients to be at least 30 or 40% better on those rating scores with their medications than without it. And that makes it very clear to the patient as well as the doctor of what symptoms get better. And we know how to correlate that with what we'd expect from the stimulator, so everybody has a good idea of what to expect from surgery. The final test to see are you a good candidate for the surgery is a memory test. So this is called a neuropsychological test. It's a pencil and paper test. It takes about 2 hours with a neuropsychologist, and they test all different kinds of cognitive function to make sure that we don't have dementia or significant cognitive impairment, because we know that the DBS is not going to improve these parts of the disease. And in some cases, things can get worse before they get better. So we don't want to risk things like that. So once the decision between the surgeon and the neurologist and everybody is that the patient's a good candidate, then surgery is an option. So the way that we put the system in is done via 2 different surgeries. The first surgery is when you put the wires or the leads or the electrodes are called into the brain. And most often patients have significant disease on both sides of their body. So we'd put one wire in each side of the brain to help the opposite side of the body. So this surgery is a very precision guided placement because the targets that these electrodes have to go to for the best effects are very small. So there's different ways to do this. The most common way is to do it with patients awake using off and on short acting sedative medications through the IV with the anesthesia team and local anesthetic so that the brain cells are awake and we can identify those targets very easily. If for whatever reason it's not possible to do this sedated and awake, a sleep DBS is an option. The patient then recovers from the electrode implantation in the brain and goes home from the hospital the next day, usually, and then would come back in for the second part of the surgery, and that's when we connect the brain leads or the electrodes to the extension wires and the pulse generator or the pacemaker or the battery pack in the chest. So this surgery does not require any mapping or testing, and it's all done asleep under general anesthesia. And it's also an outpatient surgery. So what the DBS consists of is three components. So one is the battery pack or the pacemaker, and this generates these electrical impulses that are sent via an extension wire up to each electrode that goes into the brain wires. And like I mentioned, usually this is one wire on the right side of the brain and one wire on the left side of the brain. There's different configurations of the electrodes, but there's multiple different ring electrodes on the bottom of the leads that the neurologist can choose which contacts are the most helpful and avoid any kind of stimulation-induced side effects to get the patient as tuned up and as optimized as possible. So the precision guidance that I mentioned is done basically via computer and MRI guidance. So that requires a fiducial marking system. So this is what a halo would look like. So the morning of surgery, after numbing medicine is injected at each of these pin sites, the ring is placed and we get a new scan with the ring on, and we can merge this ring with the halo on with the preoperative MRI scans. We get a very high resolution picture of the brain structures that we're trying to target. So this is what a brain MRI looks like. And that's a much better picture of the brain compared to a CT scan, for example. So however, with the ring on, then we can see these 9 white dots around the edges. Those are called fiducial markers. So the computer can calculate the distance from these targets to these fiducial markers and to the patient's specific anatomy. And it gives us a very accurate way of placing these electrodes in the target. So we use a coordinate system to know how far and how deep and where we need to put this to know where that target should be. So this is a very good method. It's very accurate. However, it's not perfect. There is some kind of tolerance within the system so that sometimes little adjustments need to be made during surgery. And that's the benefit of having patients awake at surgery. So after the CT scan is done, the patient's taken to the operator room, the sedation is started through the IV. The head is supported within the frame, so it holds the head really still and lets the patient relax so that they're as comfortable as possible. And it's kind of like a recliner or a beach chair type position. So everything on this side of the frame is sterile and clean. But we still can see and talk to the patient, and the patient can see out the bottom of the ring. So it's as comfortable as it can be. The second way that we can identify these targets are we listen to the brain cells fire. So this can be done with a needle type electrode that goes through the brain tissue down to the target. And by listening to the brain cells fire, we can determine that this is the top of the target here. This is the bottom of the target, so that if we need to make adjustments and be sure that we have a good location, we know exactly where we are and where we need to be. So what we hear are the brain cells firing which sounds a little bit like static, but this is what it sounds like. So it could be much more quiet above the target, gets more loud in the target, and it gets quiet again when you go out the bottom. So this is a very accurate and the most accurate way to know that we have the electrode in the right spot. And oftentimes we'll use 3 different electrodes and we pick whichever of the 3 is the best sounding and best looking on a computer screen to know that we have the best location within the target in the brain. So what we see is a computer screen, and we can see 3 different electrodes, for example, and we see the brain cells firing. That's why these lines look thicker. So if the brain cells are firing a lot, the line gets really thick. And if it's really, really quiet, the line gets pretty skinny. So we can use computer measurements to calculate exactly where we are. And in this case, electrode 1 is the best location within that target. And that tells us that we would want to put the DBS electrode in the electrode 1 position. And this technology has gotten better and better and better. So the computer actually will give us a recommendation of what it thinks is the best location also. So this is an extremely precise way to get down to fractions of a millimeter of accuracy. And then this is kind of a side view of another patient, for example, to kind of show that the arms are open and exposed so you can move your arms. And the legs are similarly available to move. So you can shift around as you need to be comfortable. This is the anesthesia doctor in the green here. And we talk to the patient and we ask them to move their arms or simulate movement so that we know that we're in a good spot and we have good stimulation effects without getting any kind of side effects. So the best effects are if we accurately position that electrode in the target. So if we're a little bit off one way or the other, sometimes we get very strong tingling, for example, or sometimes we can get tightness or cramping, which is what we don't want to get, obviously. But that tells us when we do the test stimulation, and the whole reason that we keep patients mostly awake during the surgery is to know that these effects are not happening, so we don't have to do any kind of adjustment. But if we need to, we can do that adjustment right then and there to get the best long-term effects. So once we have both electrodes positioned, we kind of lock them in place with a little dime-sized plastic cap that gets attached to the skull underneath these small little incisions. These incisions are about 1.5 inches long. And as I mentioned, one on the left side of the head and one on the right side of the head so that both wires go in. And this is kind of what our stereotactic frame looks like to give us that very precise accuracy. So the patient then recovers and goes home. We do observe them in the hospital overnight for any kind of complications from the surgery. We usually get a brain scan to be sure there's no surprising blood clots or anything like that. And then if everything is okay, the patient goes home the next day. Second surgery typically happens 10 to 14 days after the first one. And it's an easier procedure to have because you don't have to have the halo on your head because all the precise targeting and positioning of the electrodes is already done. So then we can do this whole surgery with you asleep under general anesthesia. And all we do then is connect the tail ends of the brain leads to the extension wires, and we tunnel these under the skin from the top of the scalp to the side of the scalp, and then from the side of the scalp to the pacemaker incision in the chest. So this is an outpatient surgery. You go home the same day, and even though everything is implanted, it's still not turned on yet. And then you recover at home, and then you come back to see the neurologist. And usually about a month from the first surgery would be when the system is activated. That way, any kind of temporary effects from the surgery are gone, and you're kind of back to your normal self, and you take your normal Parkinson's medications that whole time, just like normal. There does tend to be a little bit of a honeymoon effect after the first surgery, and the good honeymoon effect is that some of the rigidity and stiffness and dyskinesias from the medications will be better for a few days. The bad honeymoon effect is that mentally you'll be a little bit more sleepy or not want to be as active. Some patients even get a little bit confused for a few days, and then that is a temporary effect. And then usually about a week or so from surgery, you're kind of back to your normal self. So that's why we wait to turn this on about a month, 4 to 6 weeks after the first surgery. So once it's turned on, it is then a commitment. So you have to come back and see your movement disorder specialist neurologist every 3 to 6 months for periodic adjustments. And as the stimulator is turned on and the doses or the stimulation is increased, usually we can cut back significantly on the medication. So the neurology will balance the stimulator settings as well as the medication settings. The battery life depends on the how much energy and current the brain needs to be as tuned up as possible. So patients on lower settings might get 6 years out of a battery before it has to be replaced, or patients on higher settings might be closer to 3 years. So that is another surgical procedure to reopen the scar in the chest, take that entire pacemaker unit out, put a new one in, stitch up the wound. You go home, it's turned on the same day, but that is another small outpatient procedure. We do have rechargeable batteries available now, so patients that end up on higher settings can use a rechargeable battery and charge it just like a cell phone, for example, just with a charger on top of the skin, and those batteries will last longer, but we do have to, it's a commitment to recharge the system. So we've been doing DBS at the university since 1998, and we know that it has a very strong, safe track record. It's also been used around the world a lot. So we know that it's safe and it's effective, but we can never eliminate all the risks from the surgery. So DBS does not slow down the progression of the disease. The one common risk that I worry about is infection, because if the hardware gets infected, we have to take it out. The wires are very strong, but very small. But if there's a large trauma or a car accident or things like that, the system can fracture and have to replace whichever component might be broken. The risk of something very bad happening, like a bleeding episode or a stroke, is about 2% or less. So the other thing to think about is it is a surgical procedure, so there's anesthesia involved, and there are some risks of anesthesia, things like heart attacks and blood clots and pneumonias and things like that, that we want to be aware of and keep everything as optimal as possible. So these are what some of the complications can look like. So this is a blood clot on a CAT scan. This white area here surrounding the DBS wire is a small blood clot. Fortunately, this did not cause any long-term problems or any big symptoms in this patient, but these kind of hemorrhages do happen 1 to 2% of the time. Hardware can sometimes erode through the skin, and that's a problem because then it gets colonized or coated with bacteria. And sometimes we have to, or we always have to do something to kind of either remove the system or cover this up so that the system is totally clean and sterile. This is what a fracture in a lead can look like, which we can see on x-rays. And it is very common procedure for us to do, however. So these are what our numbers look like over time, over the last 9 years. So you can kind of see the trend is increasing, but this kind of experience helped everybody on the team to make these outcomes as safe and as good as possible. So in a normal year, kind of before COVID, we were doing approximately 60 patients per year. So that's a good experience for the nurses and the anesthesia team. But that's just a testament of how common Parkinson's disease is, so that we can help as many people as possible. There are 2 different brain targets in the brain that we can use based on the neurologist recommendations. So the subthalamic nucleus, or STN as we call it, is one target and the most common target. This is shows you how common the STN target is compared to the blue line here is the alternative target, globus pallidus. So they're very much similar in their effects, but that gives us flexibility to choose whichever target is best for a given patient. But as good as DBS is, we need to do better because we know that DBS does not slow down or prevent the disease from progressing. We also know that it does not improve memory or cognitive problems. And finally, it does not consistently improve speech, and in some cases can actually make speech worse when the stimulator is turned on. So we have a very big research enterprise here at the university, and our specific areas of interest are exactly these things. So how can we improve cognition, and how can we improve speech? So we have studies going on, so please ask us if you're interested as we strive to do better, because we can do surgery or do research before surgery. We can record brain waves and do research during surgery, and then after surgery for follow-up to compare outcomes, for example, with the stimulator on compared to off, and be able to predict and hopefully improve outcomes after DBS. The technology continues to get better also. There's 3 vendors that make DBS systems, so competition is a good thing. We now have directional leads where we can shape the electrical field in different directions. As I mentioned, DBS can be done asleep if it has to. And what's coming down the pathway is adaptive DBS, where we can measure brain waves and adjust the stimulation based on what we sense. So in conclusion, we know that DBS is safe and improves motor symptoms and quality of life. We also know that it's not for everyone, and it is a commitment because you have to come back for your programming adjustments and be able to see your neurologist regularly to optimize both the stimulator settings and your medication dosage. We have a fantastic team of specialists here to help. And this is my email here at the bottom. So any questions, please contact me at any time. I'll be happy to help in any way that we can.
Hi, everyone. My name is Annie Rule. I'm a speech language pathologist here at the university and a research coordinator in the Department of Neurosurgery. Today, I get to talk with you about speech and swallowing problems in Parkinson's disease. We'll start off with an overview of the speech mechanisms and how Parkinson's can affect them. I'll talk about some speech therapy options and how speech therapy can help. I'll give you some communication strategies, just some ideas that you can take from here and use in your day-to-day life if you feel like you need them. I'll highlight some swallowing problems in Parkinson's just very quickly. And then I'll also make sure to go over when to ask for an SLP referral, a speech language pathologist referral, and talk a little bit about speech research here at campus. So I just want to highlight how important and complex speech and swallowing are. So it's a little counterintuitive because you don't have to think about either of them. You don't have to think about talking in order to talk usually, and you don't really have to think about swallowing when you're eating, but there's upwards of 60 different muscles used just to talk. You have to use 60 different muscles. This little diagram illustrates the different areas those muscles are. You know, it starts in the lungs with the respiratory system producing the force and the air necessary to create voice in your throat, in your larynx. And then that comes out your mouth where it's shaped by different muscles and articulators into words and speech that we can recognize. It's a lot to coordinate, and it's no surprise at all that a disease that affects muscle strength, control, and coordination would also affect speech. It's a complex process. Now, I'm sure a lot of you have either said or heard all of these things. People with Parkinson's tell me all the time that they get told that they're speaking too quietly, they have to repeat themselves a lot, or they're mumbling. They'll also tell me that people tell them they're talking too quietly, but they feel like they're shouting. That's really common. All of those are so common in Parkinson's because 70 to 90% of people with Parkinson's experience dysarthria or impaired speech at some point in the course of their disease. That's pretty much everyone. And it's caused, dysarthria, the speech impairment, is caused by the same thing that a lot of the gait and movement problems are caused by: impaired regulation of speed and amplitude of movement. So the same way that you take smaller steps more quickly, maybe with Parkinson's, those things present in speech as well. The other factor that contributes to speech problems in Parkinson's is impaired perception. So people with Parkinson's, like I said earlier, can't always recognize that they're talking more quietly. To them, it feels like they're shouting or speaking very loudly, and to everyone around them, it's too quiet, it's too fast, it's a little harder to understand. Somewhere in the process between hearing your own voice and adapting your speech to adjust and increase volume, there's a breakdown with Parkinson's. And that makes it really difficult to treat and recognize sometimes. So Parkinsonian speech has some common characteristics. I'm sure most of you are familiar with quiet speech. A lot of people with Parkinson's have that softer volume, which neurologists, physicians will refer to as hypophonia. You'll see that in your chart, in your notes sometimes. But there's others. So we sometimes see imprecise articulation, so slurring, short bursts of fast speech. So that fast rate can be really common in Parkinson's. And then less intonation. So people with Parkinson's tend not to vary their pitch as much. And pitch variation is how we communicate emotions and context in our speech. So without that, with that monotone, flat pitch, it can be harder to understand or interpret what someone's saying. We also hear breathiness and hoarseness in people with Parkinson's quite often. Now, someone with Parkinson's might not have any of these issues. They might have some, they might have all of them. It just varies, as everything does with Parkinson's. But these are the most common features of Parkinsonian speech. Now, it's really common and, as I'm sure you know, very frustrating to have these speech problems. But it often gets overlooked. It's not at the forefront of people's minds. It's easy for people to overlook because it's an invisible symptom. So often when you go in to see whoever manages your Parkinson's, you might not talk much about speech or swallowing, some of those invisible symptoms, but it's really important to recognize them still because they have a huge impact on quality of life. So someone with Parkinson's might have issues with their speech, making them talk less, feel like they get interrupted more, have a hard time getting their turn in a conversation with multiple people. Sometimes people will feel embarrassed, stop their usual social activities, and become kind of socially isolated because of how their speech is changing and how their Parkinson's is affecting their ability to communicate with those around them. So obviously, speech is hugely important to us as human beings. We need to be able to communicate and socialize. So it's important that we recognize and treat speech problems in people with Parkinson's early and when necessary. But a recent study found that only 7.5% of people with Parkinson's were referred to speech therapy by their doctor in a given year. That's a really low number considering that 70 to 90% of people have speech problems. Now, just because you have a speech problem doesn't mean you need speech therapy every year. Maybe a lot of people don't need speech therapy in 1 year, but 7.5% is still really low and shows that maybe we aren't recognizing and getting help for those problems when we should. So you're your own best advocate. Make sure that when you go in and meet with your healthcare provider, you bring up speech problems if you're noticing them, or if your loved ones are pointing them out, make sure and bring them up, because speech therapy has the potential to make a difference. So speaking of getting into speech therapy, what does that look like? It's always going to start with an evaluation. So you're going to go in, you're going to meet with a speech pathologist who will talk with you, see what you're noticing as far as speech problems. They'll listen to you talk, and they'll do some testing to kind of see where you're at, what problems they notice, and what kind of therapy would benefit you best. Anytime that you're going to see a speech therapist, that first session, you should talk about what you want. You should expect that you will talk with them about your goals for speech therapy. What problems bother you the most? What areas do you need help with? What's going to be best for you from speech therapy? And that'll guide what they decide to do and how they write goals for you. That being said, there are some really structured speech programs that are common and well supported for people with Parkinson's. LSVT, Lee Silverman voice treatment, is probably the most common. People are usually somewhat familiar with that one. But there's also Speak Out. They're both very structured treatments that have some amount of research behind them to show that they will make a difference and help people with Parkinson's improve speech loudness and hopefully overall intelligibility, or their ability to be understood. So those structured programs, LSVT and Speak Out, are relatively intensive. They both involve multiple therapy sessions a week for several weeks in a row. For LSVT, it's 1 hour sessions 4 times a week for 4 consecutive weeks. LSVT is very focused on one thing, and that's increasing speech volume. So their mantra is think loud. They work on increasing speech volume and getting rid of that soft, quiet voice. The piece that's important here for both of these programs, and really for speech therapy in general, is that the program should include homework or home exercises that need to be completed daily, or at least after therapy is discontinued. So once you're through your 4 weeks of LSVT, you should still be doing those exercises. For Speak Out as well, that motivation and dedication to continuing the exercises after treatment is really important to maintaining whatever gains are made in therapy. I'm sure that any physical therapist would say the same about exercises there. We have the same goals with that. Speak Out is a little bit different from LSVT in that it's a 2-part program. So you start off with that intensive one-on-one therapy, and then they offer a group therapy component called Loud Crowd, which kind of helps support carryover and continued exercise. So you need to do those home exercises still, but you also get to do them in a group setting where you're kind of held accountable for it. So those are 2 structured speech therapy programs that you may encounter. Both of them require the speech therapists to be trained to some degree. So it's worth, if you're interested in one of them, looking it up and seeing where you can find a trained speech therapist. I know that there are many here. I know that the speech clinic on campus, Wendell Johnson, offers both, and most clinics have one or the other. Now, just because there are structured therapy options doesn't mean everyone's going to follow them. If you aren't quite a good fit for certain therapy, or the therapist thinks you would benefit from something else, you can expect it to incorporate improving awareness and perception of that quiet voice, over enunciating, slowing down, all of those different pieces. And then also, you can sometimes encounter respiratory muscle strengthening programs that's working on increasing the expiratory strength to increase speech volume. So if you get stronger abdominal and chest muscles, you can increase your volume by increasing the airflow. There's also wearable devices that you put over your ear and they play white noise to trigger a reflex that automatically increases speech volume. The Speech 5 is the one that I'm familiar with for those. And it's a good option if you want something that you don't have to think about. And then there's always other options that can help support communication. So augmentative and alternative communication systems like devices, communication boards, even something as simple as writing things down if someone's not understanding you, are all things that you can learn about and work on in therapy with a speech pathologist. I have a list of kind of communication strategies here for you, just things to give you an idea of what might help in different situations. So to start with, thinking loud, we're going to take that. Make sure you're standing up straight or sitting up tall, taking deep breaths and really supporting your voice from your diaphragm to get that louder voice without straining. And then over enunciating, slowing down, all of those things are going to help you make your speech a little clearer for the individuals that you're talking to. Practice. If you have a specific situation where you might encounter difficulty, like a big phone call, running through it once ahead of time can help you remember things without having to think about so many things at once. Looking at the person you're speaking to is a good tip for anyone. It'll help them use your mouth as cues for what you're trying to say. And it also projects your voice directly toward them. Gestures, props, pausing to make sure that they understand what you're saying and give them an opportunity to ask questions. Letting them give you reminders on speaking up or slowing down. And then advocating for yourself. All of those are tips, some things you can try for communication going from here. Okay, so on the other side of things, some tips for caregivers and communication partners. Be patient. Remember that with Parkinson's, it's hard to recognize when you're speaking quietly. And it can also be hard to realize when someone's not understanding what you're saying or why. Clarify, ask questions if you're not understanding something. Turn off the TV, find a quiet environment. Don't interrupt. Leave pauses in conversations and make sure that you're including individuals with Parkinson's. That's again, it's easy for them to get overlooked and feel more isolated. I'll go through some swallowing issues that sometimes arise with Parkinson's. Patients can have trouble with the oral stage of swallowing. So that's things like managing saliva, it's where you see drooling. Chewing efficiently, it can become more difficult and taxing to have to chew foods, or getting food from your mouth to the back of your mouth to swallow it. Can all be affected by Parkinson's. And then the pharyngeal stage of swallowing, which is after the food leaves your mouth while it's going through your throat. We sometimes see things like food feeling like it's sticking in your throat, coughing or choking during meals or when you're eating or drinking. And aspiration is a sign of a swallowing, or happens from a swallowing impairment. Aspiration is essentially when food or liquids enter the airway toward the lungs, which can happen easily if something goes awry in the swallow. If you look at this zoomed in image of the throat, this green arrow is pointing toward the esophagus, which connects the mouth to the stomach and is the path that food should take. But right next to it, we have the trachea down to the lungs. So since we use our mouth for both eating and talking, the two pathways have to be pretty close together, and there's always the risk that food or water can go down the wrong pipe. That's where you notice, coughing, choking during meals. With Parkinson's, we also have a little bit of decreased sensation, which means that you might not always notice or get that cough response that your body initiates when something enters the airway. And it also, because of the coordination and muscle control movement issues with Parkinson's, aspiration becomes more common. Aspiration is dangerous because it can result in pneumonia. So when we talk about swallowing problems in Parkinson's, this tends to be people's number one concern besides discomfort, because it is a risk that it'll lead to pneumonia. Now, preventing pneumonia isn't all about preventing aspiration. Of course, if you notice that you're coughing or choking during meals or having recurrent pneumonia, a swallowing evaluation is always warranted, and you should definitely talk to your healthcare provider about that. But there are some other factors that can actually have more of an impact and be stronger predictors of pneumonia. For example, oral hygiene. So the best way to prevent pneumonia is to brush your teeth, clean your dentures, floss, mouthwash, take care of your mouth every day really thoroughly. Clearing out the germs in your mouth makes sure that those germs don't get a free ride down to your lungs. The other predictors for pneumonia and Parkinson's disease are actually independence with feeding. So if you're able to feed yourself safely and well, you're less risk for pneumonia than someone who needs help with eating. And then mobility as well. So someone who's bedridden is going to be high risk of pneumonia, or someone who is dependent on a wheelchair is also higher risk of pneumonia than someone who's up and walking on their own. So both of those things are actually ways that occupational or physical therapy can help prevent pneumonia. If you're having trouble feeding yourself, occupational therapy always has fantastic suggestions and tricks for that. And physical therapy, occupational therapy to get you up on your feet, moving better. Making sure that you're doing those things can actually help prevent pneumonia, decrease your risk of getting pneumonia, even if you are, even if you are having some amount of aspiration. Doing all of those three things can help protect you. That being said, swallowing evaluations are important to get done early if you are noticing changes. So signs that something's going on are, like I said, food sticking in your throat, coughing or choking coughing or choking during or after meals is a big sign. And just increased frequency of any of those things. Clearing your throat after meals or during meals a lot is also your body telling you that there's something sitting in your airway. You're trying to eject something from your airway by clearing your throat. So watch for some of those signs if you notice increasing frequency or if they become problematic or challenging. Let your healthcare provider know for sure. A swallowing evaluation generally looks like meeting with a speech pathologist to talk through the issues you're noticing. And then often they will either do an X-ray test and watch you swallow on X-ray, or watch in your throat as you swallow to see if they see any particulates, any material going down the wrong pipe, getting into your airway. Depending what they see on that evaluation, they might make recommendations for swallowing exercises, positioning changes, changes to your diet, and the types of food you eat, things that will make it safer for you or easier for you. So swallowing evaluations can guide recommendations for what's next if they notice problems. Now, with all that in mind, when should you ask for a referral to a speech pathologist? Like I said, if you notice increased coughing, choking, or throat clearing during or after a meal, or if you're having discomfort with eating, pain, difficulty chewing, or feeling like food is sticking in your throat. And as far as speech, it's when you feel like you need it. That's could be early, could be later. It's all dependent on if you feel frustrated by your speech, if you're having to repeat yourself a lot, if you're feeling more isolated because you're struggling to communicate, or just want some suggestions on how to do better with something, communication tasks at work, at home, various things. All of those are perfectly valid reasons to see a speech therapist and get some ideas and work on intelligibility and speech. A few links here, more information on the treatments, our speech clinic here on campus. And then I will just really quick talk about speech research in individuals with Parkinson's. So there are always so many different questions to answer related to Parkinson's, obviously, but even related specifically to speech. It's such a small area, but there's a lot that we don't know because it's not super well researched. So some questions that are out there that we have yet to know answers to are: what speech treatments are effective for improving speech in people with Parkinson's? So we know a few. We have LSVT, we have Speak Out, but they don't always work for everybody. There's always something else out there, and people always have different ideas of what's working. What medical interventions improve speech? We don't know how medicines for Parkinson's affect speech. We don't know really how deep brain stimulation affects speech. We don't know what makes speech worse for people with Parkinson's, if medication's wearing off or fatigue. All of those things can make speech worse, and we don't really know why or how. There's just a lot out there about how Parkinson's affects speech, and how we can improve that for people with Parkinson's. Now, here, our current study that I'm primarily working on, we're looking at how deep brain stimulation affects speech. So Dr. Greenlee works with so many people with Parkinson's that see fantastic improvements in their physical motor symptoms, but speech does not respond the same way. And we are trying to figure out why, and if we can predict or find links between anything. So basically, we're asking, how does deep brain stimulation affect speech over time? How is it different for individuals without DBS? How do different parts of speech, like voice, articulation, speed, impact people's ability to understand people with Parkinson's? How does brain activity correlate with speech changes in Parkinson's? And how do speech changes relate to motor changes? So why don't they both improve when we see improvements? All of these are questions we're trying to answer right now with the studies that we're doing. With a lot of data collection. I love working here at the university because we have access to so many wonderful people and collaborators. It's a wonderful setting to be in. This is an overview of some of what we're doing. Right now with our study, we're having people come in, record speech before surgery, and then 6 months and 12 months later so that we can compare over time. We're doing that for people who are undergoing deep brain stimulation surgery and people with Parkinson's who are not having surgery, just so that we have that group to compare directly to still through those 3 time points. Okay, so in summary, don't ignore speech and swallowing problems. Ask for a referral if you have any concerns. Speech pathologists are your friends and can make a difference there. Try out some of the strategies that I mentioned if you're having issues. It's not going to solve everything, but it can make a difference. And then keep an eye out. We are always looking at speech in Parkinson's, and I'm sure there will be a lot of research coming out. Thank you all so much.
Good morning, everyone. My name is Rachel Rose, and I'm an occupational therapist at UI Healthcare. I hope you had a great morning so far, and I'm here to lead you with some breathing exercises, some arm stretches, and we'll do some trunk rotations and finger flicks as well. And then Stephanie, my colleague, will join in and do some lower extremity movements as well. So, all right. First things first, make sure that you have things out of the way in case you were to kind of knock something over. Just kind of push it out. We'll be reaching today. And then next thing, make sure you have a sturdy seat. And you're going to sit up nice and tall, feet on the ground if you can. And remember not to force anything. Just do what you can. And I'll kind of talk a little bit about modifications too. So here we go. So we're going to start with some breathing to begin. And we're going to start in this position, almost like you're going to box. And we are going to breathe in through your nose and then out through your mouth. And you can do one of 3 breathing techniques. The first one will be pursed lips, like you're blowing out birthday candles. So the second one being an SH sound, so a shh. And the last one being just an S sound, like a snake. And that's really gonna, put your core to work, okay? So we'll do 4 of these, just mirror me. And remember to be nice and tall in your chest, shoulders out. And then for your back, if you have 2 shoulder blades, just make sure that They're touching, okay? All right, ready? So we're in the start position, and you're gonna breathe in through your nose. Open up the chest and breathe out. And 2. And breathe out. 3. And 4. Make sure you're squeezing those shoulder blades. Good. Okay. Now the next exercise we're going to do, we're going to be reaching. So you're going to be weight shifting through the right side and the left. And we're going to add an arm component to that. So make sure you're reaching like you're putting something away on the top shelf, and then back to center. And reach, back to center. Reach, back to center. Reach, back to center. And with these, you can continue your breathing. So we're going to breathe in and out. Breathe in and out. Good. All right. And number 3, the third exercise we're going to do is with your core and trunk. So I'll have you take your left hand. I might be opposite than you, but your left hand, and you're going to place it on your right knee. And if this is enough of a stretch for you, you can hang out right here. Or you can take your right hand and stick it behind you. And you're going to look to the right side. And you're going to get a nice twist. Don't force or really pull anything, but we're going to hold it here. We're going to breathe in through your nose, out through your mouth, and return back to center. We're going to take it over to the left. So take your right hand, place it on your knee, and you're going to reach and look to your left. Breathe in through your nose and out through your mouth. Good, back to center. Now we're going to do 4 more of those, okay? Let's go to the right. Breathe in, chest tall, and out. Over to the left. Breathe in, nice and tall, and out. Good. Keep it going. Breathe it in through your nose, out through your mouth. Take it to the left. In through your nose, out through your mouth. Let's do 1 more for good measure. Over to the right, last one, make it your best one. Breathe in and out. And try and stay tall on this last one. Chest high. Good job. And last to finish up, if you worked with me, you know I love these. They're great for your hands to wake them up. We're going to start fists kind of up near your chest, and we're going to open and extend all your digits wide. Feel a great big stretch. We're going to do it 5 times together. 1, 2, 3, 4, 5. Good. All right. And I'm counting, but you can work on your breathing during these as well. Ready? 5 more. 1, 2, 3, 4, 5. And then your last one, you're going to do a last set, and I want them to be your biggest one. You can even add some elbow motion into it as well to end the movement. So we're going to go 1, 2, 3, 4, and 5. All right. Good job, guys. Hope you enjoyed this little upper body stretch, and I'm going to get Stephanie, and she's going to take you through the lower body. Have a great day.
Hi everyone, my name is Stephanie Evans. I'm a physical therapist for UI Healthcare. I am going to get your legs moving a little bit. So these exercises can be ones that can be done if you have issues with your blood pressure being kind of low and you tend to get a little lightheaded when you stand up, these ones are good to remember to incorporate. So the first ones we're going to do is heel raises. So I want you to work on pressing up to your toes and putting your heels back on the floor. Up big, down to the floor. So we're going to do 5 more of these. 2, 3, 4, 5. Good. Next one, I want you to stay sitting up tall, and we're going to work on a big march. So again, I want these movements to be big and slow. So we want everything to feel very deliberate. And let's go up, down, up, down. If you need a little bit more support, you can put your hands on the arm of your chair or down by your sides to get a little bit better lift. But for added challenge, hands on your knees to really make you have to shift your weight side to side. Let's do 1 more on each side. Good. Okay, we're gonna increase the difficulty a bit with this. And the next one, we're gonna raise opposite arm with your march, okay? So big reach up towards the ceiling. Good. Opposite arm, opposite leg. Good, let's do 2 more on each side. Very good. Okay, next one, we're gonna do a sideways step. So I want you to step out and back, out and back. And it's really easy to rush these exercises. So I want you to pretend that you're stepping over something. Maybe you have a hurdle, little hurdle there. Your dog's sleeping down here. I want you to keep it nice and big and slow. Out, together, out, together. Let's do just a few more side to side. And again, if you need a little bit more support, you can have your arms on the armrests of your chair, or you can have it down at your side. Last one. Good. All right, let's do a reset of our posture. And the next one we're gonna do is add another degree of difficulty. We're gonna add a reach with it. So you're gonna try to reach out at the same time you move that leg. Out, together, out, together. Nice slow cadence, big deliberate movements. And keep those fingers spread nice and big too. We're gonna work on a little bit more of the arm stretching and hand stretching when you do this one. Good. All right, nicely done. For the next one, for those of you who know me, you're going to be really familiar with this one. I give it to all of my patients. I want you to work on standing up from your chair and sitting back down. So if you need to take a minute, go ahead and slide your chair back, get yourself positioned. And for safety, you can use your arms to push up. Or for a little added degree of difficulty, you can try the big reach, where you reach forward and stand up and come back down. Stand up and come back down. Okay, we're gonna do 5 in a row. 1, 2, 3, 4, Make sure you're getting that head clear forward. 5. Very good job.
Good morning, I guess it is. My name is Kumar Narayanan. I'm from the University of Iowa's Division of Movement Disorders, and I'm here to give you a whirlwind tour of exciting research happening here at the University of Iowa on cognition and speech in Parkinson's disease. And I'll be able to talk about some exciting disease-modifying therapies that we're studying here at the University of Iowa and that we'd like you to be involved in. So I'll talk a little bit about diagnosis of cognitive and speech symptoms of Parkinson's disease. I'll give you a snapshot, and this is going to get pretty scientific, but I think it's important to show you that the basic science that we do here at the University of Iowa matters. So I'm going to dive into the mechanisms, and then I'm going to talk about some exciting new directions in neuroprotection here at the University of Iowa. Before I get started, I wanted to talk briefly about Parkinson's disease. You might think about Parkinson's disease increasing in frequency, becoming more and more significant. It's certainly significant in all of your lives and in all of our lives here at the university as we work hard to care for you and all of the manifestations of Parkinson's disease. When I think about the future, though, I think about a tidal wave. People in Iowa are living longer, and Parkinson's is a disease of aging. And if we don't come up with new therapies for the tidal wave of Parkinson's patients that are coming, it's going to be hard. Sometimes I feel like I'm in this boat looking at this tidal wave, and we need to come up with new approaches, new therapies. So to start with, Parkinson's disease is a motor disorder. It's taught in movement disorders and neurology. This is an early image of patients with Parkinson's disease drawn by a famous neurologist, Gowers, almost 120 years ago. And certainly Parkinson's patients have motor symptoms, and that's something that they struggle with. But we're realizing that Parkinson's patients have far more than motor symptoms. We notice, so the motor symptoms include tremor, bradykinesia, which means slow movements, rigidity, which means stiffness, and posture instability, which means this propensity to fall. But we're recognizing that Parkinson's patients have all kinds of other symptoms: lack of smell, sleep disturbances, cognitive function, communication deficits, mood disorders, constipation, bladder dysfunction, excess salivation, and orthostatic hypotension, among a few. So in this sense, Parkinson's disease is really a systemic disease. And some of these symptoms, like the sleep disturbances that lead to cognitive dysfunction, deficits in short-term memory, planning and reasoning, communication disorders, that lead to soft voice, difficulty forming the words, we call this dysarthria, cognitive difficulties sequencing the words. These problems really get in the way of patients' lives. They really ruin patients' lives when we deal with them. And they dramatically impair quality of life. They actually independently predict nursing home transfer, and they predict morbidity and mortality that seem to be big factors of the disease. So, we really struggle with these things in clinics, and we need new treatments. So that's a snapshot of the symptomatology of Parkinson's disease that involves cognitive and speech deficits in Parkinson's disease. And neurologists haven't recognized these much because, for the first almost 200 years of the disease, we didn't spend a lot of time talking to our patients. But we need better approaches. And the first way to think about that is we need a better way to diagnose these aspects of Parkinson's disease. One potential is something called EEG. EEG is a very old technique. It stands for electroencephalography. And basically, it's a set of electrodes placed all over the brain. And these electrodes were able to they're placed all over the scalp, typically by a cap like this. And they're able to identify small changes in voltage. Of course, the biggest changes in voltage that happen often happen with neurological diseases such as seizures. But we're noticing that patients with Parkinson's disease can have abnormal brain rhythms. And I want to give you kind of a version of what that might look like. So if we were to play a loud sound, 110 decibels, train going across the tracks, you would see this wave over this part of the brain. We call that electrode CZ. That's in patients without Parkinson's disease, young patients. We noticed, our lab noticed, that in Parkinson's patients, this rhythm was markedly attenuated. That Parkinson's patients in general, had a decrease in this rhythm. And so if there are any engineers in the audience, they'll appreciate a spectrogram, Fourier transform. I'll walk you through it here. On the y-axis, the bottom line is time, and then the x-axis is frequency. And what you notice is there's a lot of red around 4 hertz, which is 4 times a second. And that's pretty prominent in patients without Parkinson's disease. But in patients with Parkinson's disease, this rhythm is markedly decreased. So, we wondered, could we use these rhythms to diagnose these cognitive and speech symptoms of Parkinson's disease? So what we did is we took 100 patients with Parkinson's disease, and many of you who are listening to this participated in this study, which was very intensive, took a long time. And we had patients perform some of these tasks. We looked at these rhythms around 4 hertz and we quantified them, and we were able to get a single number for each patient. So here are some control patients without Parkinson's disease. Here's the 4 hertz, we call it power. So how loud or how big that 4 hertz signal is. Control patients tend to have power that's positive. They tend to have power that we could detect. Patients with Parkinson's disease, we noticed, had slightly less power. And you can see here that this power is variable, but in general, the black bar is what we call the median, so half the data. The Parkinson's patients tended to have slightly less. Amazingly to us, Parkinson's patients with cognitive impairments, that is, patients who had not normal cognitive function, who had deficits in short-term memory, deficits in kind of planning, had even less cognitive impairment, or even less 4 hertz power. And finally, Parkinson's patients who had dementia, meaning they had profound cognitive impairments, had kind of the fewest or the least of these 4 hertz rhythms, almost close to this 0 range. So this is significant to me, at least, on several accounts. First, it means that we might be able to do these EEG techniques and identify our patients who are demented or patients who have cognitive impairments. And it would be useful to know. Right now, the gold standard is 4 hours of neuropsychological testing in clinic. But we can get this in maybe 10 minutes of EEG data. And we've actually designed machine learning algorithms that are highly predictive, correlation coefficients that explain something like 40% of the variance. And machine learning algorithms can predict with very high accuracy, 80–90% accuracy, who has dementia and who doesn't, which is so useful because it's useful for identifying these patients, getting them treatments. So there are all kinds of treatments for the patients who have dementia and cognitive impairments. These treatments, the state of the art currently, might include normalizing sleep, avoiding medications such as Benadryl, or medications such as oxybutynin, or even the ones we struggle with the most, Xanax, lorazepam, narcotics. We might avoid those, or if these patients are having cognitive impairments, we might take them away. We also can help we can help talk to people about it, and we can help structure patients' lives so that they can live their best life with these cognitive impairments. And finally, we have some treatments that may be able to help, cognitive rehabilitative therapy, or a drug like rivastigmine or donepezil. So identifying these patients is very important, and we think we can design EEG algorithms to do that. All right, so I've given you kind of a vision of why patients with Parkinson's disease, or EEG, how we might use the EEG to diagnose these patients. What are the basic mechanisms involved? And this is going to get super scientific, super fast, but I think it's worth it because it gives you an insight of kind of how hard we wrestle with these things here at the University of Iowa. So Parkinson's patients have kind of impaired timing. That is, when they estimate an interval of 7 seconds, they tend to have some slight challenges with that. And this is important because how you sequence your movements in time is important to cognitive function, such as, how if you're to plan something or reason, you have difficulty timing, but also with things like speech, where you have to sequence your words, your ideas, and your thoughts in time. What we noticed is that when we ask patients or controls are demographically matched participants who, and I think many of you participate in this study. To participate in our study, Parkinson's patients had to estimate an interval 7 seconds, as did the controls. We noticed that the controls were a little bit more accurate in estimating the start of that 7-second interval. So it wasn't the Parkinson's patients were slow or fast, it was that they were more variable. And just knowing that, if, I know that if I'm playing darts and I'm more variable, I might take some extra time and pay attention to, throwing darts, and hopefully I can be more accurate. And so just telling Parkinson's patients, hey, listen, you might be a little bit more variable in how you estimate elements of time. You might use a watch, you might, use more cognitive strategies. So just saying that can be helpful to patients. But what we noticed is this variability was kind of reliably increased in humans with Parkinson's disease compared to demographically matched controls. So this finding, though, enables us to dive deep into the animal world. Animals can also estimate intervals of time. And in some animals, in rodent models, we can specifically block dopamine in specific brain areas. So you may not know this. Now we're ultra down in the weeds, or as we say, down in the brainstem. Parkinson's disease involves dysfunctional dopamine neurons in the substantia nigra and in the ventral tegmental area. And these two nuclei deep in the brain contain the neurotransmitter dopamine. And in humans, we really can't do anything, but in rodents, we can specifically deplete dopamine with a toxin, 6-hydroxydopamine, and we can ask, what are the contributions of these areas to timing? So this is what I did. So I'll remind you, here's the human data where we have controls, patients with Parkinson's disease, Parkinson's patients with increased variability. We can take away dopamine in the substantia nigra, which is the classic area for Parkinson's disease. We know this area controls movement, but it did not seem to affect timing variability. However, there's a nearby nuclei, massively understudied in Parkinson's disease, called the ventral tegmental area. If we take away dopamine in this nucleus, we see an increase in timing variability. So all of a sudden, this is exciting because we've gone from, we don't know why Parkinson's patients have cognitive and speech symptoms, to there might be a specific dopaminergic nucleus and a specific projection that we can study in rodent models. And we have a lot of techniques to record from these neurons in the ventral tegmental area, to manipulate them specifically, to see where they go. One place they go is in the prefrontal cortex. And we can actually use rodent kind of drug techniques. So we can put a little cannula, about 100 microns across, into the frontal cortex of rodents. We can block specific dopamine receptors. You may not know this. There's a D1 type dopamine receptor and a D2 type dopamine receptor. So we can try to identify which of these receptors are most involved. And this is exactly what we did during our timing test. So here you can see this is an animal's response rate. The x-axis is time. And you can see with vehicles, that's when we put saline, salt water into the brain. When we block D2 dopamine receptors, we see that their timing isn't affected very much. But if we block the D1 type dopamine receptor, timing is completely flat. We can come up with a measure of that, how curved these time response histograms are. Here's saline and here's D2 blockade. If we block the D1 dopamine receptor blockade, we see this dramatic impairment. So you can ask, why is Dr. Narayan torturing me with this finding about dopamine receptors. Well, this is amazing because for me, we've gone from, we don't know what causes cognitive symptoms of Parkinson's disease to a system, the ventral tegmental area dopamine system, and a brain area, the prefrontal cortex ventral tegmental area projection, and a receptor system, the D1 type dopamine receptor system. And if you are an aficionado of dopamine neurotransmitter systems like me, you will think, oh my God, we have no treatments that target the D1 type dopamine receptor, aside from clozapine, which is difficult to use and hard. And clozapine actually is an old drug, but has too many side effects for us to use regularly. Pramipexole and ropinirole, which some of you are on, hit the D2 dopamine receptor. So this is exciting in a potential future research direction. We're trying to work on drugs that target the D1 type dopamine receptor system, could be very helpful for cognitive and speech symptoms of Parkinson's disease. So, okay, now it would be okay if all y'all out there fasten your seatbelts, because what I'm about to tell you is ultra exciting. New neuroprotective therapies here at the University of Iowa that we think have potential. All right, so hopefully, check your seatbelts. So mechanisms lead to understanding, which leads to new diagnostic tools and treatments. So we are really focused on mechanisms. I'll give you an example of how that might work. So we know that Parkinson's patients involve energy deficits. Parkinson's patients have reduced metabolism. This comes from genetic evidence. So there's mutations in metabolic energy pathways that lead to Parkinson's disease. If you're in an environment, here in Iowa, we have lots of pesticide exposures. Those pesticides poison this energy system. We also know that the biggest driver, of metabolic deficits is aging. So as you get older, your brain doesn't process energy as well. The key currency of energy in the cell is ATP, adenosine triphosphate. And we know that if you have less ATP, less glycolysis, less energy, it could lead to protein aggregation and neurodegeneration, which we think contribute to Parkinson's disease. So question, what would happen if we could increase brain ATP? So actually, it's pretty hard to do. Your body regulates ATP obsessively, but a collaborator here at the University of Iowa, Mike Welsh, who's actually one of the pioneers in cystic fibrosis research, and his former student, who's now in China, Lei Liu, discovered that there's this drug out there, terazosin. It's a prostate drug, but it has another target, this ATP generating step in a part of the cell biology pathway called glycolysis. Terazosin seems, if you can see here on the right, seems to boost ATP at these doses. So as terazosin binds to this enzyme, PGK1, phosphoglycokinase 1, it seems to help ATP in the brain, in a part of the brain called the striatum in mice. Super exciting. So here's this drug that terazosin is given to lots of people for prostatic hyperplasia, but it also has a side effect that it seems to boost brain ATP. So we asked the question, does it do this in humans? This is from work that was just published by Jordan Schultz. So on the y-axis here is ATP measured in the human brain of some Parkinson's patients. I know some of you are out here who participate in our trial. And here's blood ATP measured. So we randomized patients. Some patients got what we call placebo, which means got a drug that was essentially a pill that didn't have anything in it. And some patients got terazosin, and we measured their ATP 12 weeks later. And you notice that in 4 out of 5 patients, their brain ATP measured by magnetic resonance spectroscopy went up. And this was not the case in our placebo group. You also notice that in the blood ATP in 4 out of 5 patients, it also went up. And it's wild, just wild that the same 4 patients, D, A, K, and B, went up in both conditions. Really, really exciting. And this is extremely rigorous. It's a placebo-controlled trial, but I will give you that it's small. It is not that many patients. It was a pilot trial that just completed here at the University of Iowa during the pandemic. So we're pretty excited. So we have this drug, terazosin, that can increase ATP in humans and in mice. Does it slow progression of Parkinson's disease? So we asked this question. We looked back at the Parkinson's Progression Markers Initiative database. And what we found is that patients taking terazosin had slower PD progression. Again, not many patients. You can see this is like 13 patients On the y-axis is the MDS-UPDRS Part 3. It's a measure of motor disability in Parkinson's disease. You can see here that, pretty variable, pretty noisy data. What we looked is the PPMI database measured people every about 3 months. And you can see that this kind of spreads out. The first measurement is here in time 0. But we noticed that patients taking trazodone did not progress as patients not taking trazodone, the controls, or patients taking another drug, alpha-1 drug like trazodone, also given for benign prostatic hyperplasia. Those patients seemed to progress, but the patients taking trazodone did not progress. That means that the MDS-UPDRS stayed stable. This was ultra exciting for us because it suggests that trazodone, which increases ATP, we think, in mice and humans, seems to slow the disease down. Even more exciting, because trazodone is given to lots of people, it's been given since 1991, we asked, we can look back at all Medicare healthcare claims data. And we called up our friend, actually emailed a friend in Denmark, who looked at their Parkinson's diagnosis data for patients taking trazodone, and we compared them to patients taking tamsulosin, which is a drug also given for Parkinson's disease, also given for prostatic hyperplasia. Neither one of these drugs have anything to do, we thought, with Parkinson's disease. Tamsulosin does not increase ATP. All right, and we looked at patients who were out there in the world, did not have Parkinson's disease, and we asked, what is the chance that these patients get Parkinson's disease? What is the risk of Parkinson's disease? So here on the y-axis is the risk of getting Parkinson's disease, and on the x-axis is time, and here's measured in years. The trazodone data are in gray, and the tamsulosin data, drug that does not increase ATP, are in orange. And what we found is that the patients taking trazodone had less of a risk of getting diagnosed with Parkinson's disease than patients taking tamsulosin. If we run the numbers, it's somewhere between 0.6 and 0.8% hazard ratio, meaning that if you're taking trazodone, you have a 60% less chance of getting Parkinson's disease or 80% less chance of getting Parkinson's disease than a patient taking tamsulosin. So this is super exciting. No drug that we know of does this. Caffeine has some protective effects. Smoking has some protective effects. Nicotine has some protective effects. But this is one of the strongest effects out there in the literature. Lots of problems with this data because we're looking back in time. It's retrospective. It's observational, meaning we're not doing a manipulation. And we have a lot of questions that we want to know about these, like, what predicts who does the best? Is there some slight difference from trazodone and tamsulosin we're not able to identify? Some people have asked us, does tamsulosin make the disease worse? And we actually have shown that that's not the case if we compare trazodone with other drugs. But it's really exciting, and something that we have a lot of hope for. But I'm going to tell you straight up, we need a top trial to rigorously test this idea in humans. And we are currently in high stakes negotiations with the National Institutes of Health to try to fund this trial, to give patients trazodone versus placebo, measure ATP, and measure Parkinson's disease. And we are going to ask you, our patients, for your help. We're going to ask you to enroll. We're going to ask you to be a part of it. You guys are the reason we show up in the morning. You're the reason we do everything we do. You're the reason we hold as patients. We are working hard. In my case, 100 hours a week, or Dr. Uch, Kara's case, all of my scientific team, we're working 100 hours a week, either caring for you or on research to make this happen. But we need your help because without you, we can't sort of make this trial happen. So we'll come ask you, hopefully a year. And hopefully this is a little bit of hope. That's why I bring it. It's spring, and hope springs eternal. So I hope that we can ask for your help. We have a center grant, a Research Center of Excellence grant focused on cognition, speech, and Parkinson's disease. I won't go into the details, but we focus on the rodent models, human prefrontal cortex. Dr. Uch leads a multimodal analysis of human prefrontal circuits. Project 2 is led by Dr. Greenlee. This is kind of the best research in Parkinson's disease across the country. And there's our kind of Google Maps shot of our research enterprise here at the University of Iowa. It's incredibly compact. The hospital is close to the research environment, so we're able to have specific advantages and come up with new breakthroughs that help patients with Parkinson's disease. Thank you for paying attention. This is my lab, and this is a book that we just edited. Don't buy the book, it's $218. If you want the book, send me a note and I will send you a PDF for free. So that's my Twitter account. Thank you very much for paying attention. Thank you for all you do for Parkinson's disease. Thanks for paying attention. And it's a pleasure to care for you. And we hope to be coming up with new therapies that make a big difference in your lives. Thank you very much.
Hi, my name is Susan Duffy, and I'm a staff psychiatrist at the University of Iowa. I'll be talking about depression and apathy in Parkinson's disease today. I have no disclosures to report. So some of the objectives I hope to cover today are understanding typical symptoms of depression and how they present in someone with Parkinson's disease, recognizing how apathy can be both a symptom of depression or its own syndrome, discuss medication and non-medication treatment options for depression and apathy, and then also hopefully provide some guidance on how to approach a loved one and caregivers about the topic of depression and apathy. So a little background, though psychiatry has come a long way, we are still behind most other medical specialties in how we make a diagnosis. For example, back before chest x-rays, doctors would make a diagnosis by taking a history and listening to a patient's lungs. But the chest x-ray has provided better reliability and more information on the severity of the disease and all sorts of other information. But with mental health diagnoses, we don't have a blood test or a brain scan that can help us make a diagnosis. So what we end up doing is asking a lot of questions. And if any of you have ever been to a psychiatrist, you know that we ask a lot of questions. And the reason we do this is to get information and to get a constellation of symptoms. And basically what psychiatrists have done is they kind of group people together based on symptom clusters. And then they use that information to study those symptom clusters to kind of see what kind of treatments they best respond to, but also kind of what the disease course is longitudinally and kind of how it ebbs and flows. So thinking about it that way, they've kind of grouped all these symptom clusters into a big book or manual called the DSM, which is the Diagnostic and Statistical Manual of Mental Illness. So looking in the DSM, the criteria for major depressive disorder is as follows. So they want people to have 5 or more of the following symptoms present for the same 2-week period, and this has to represent a change from previous functioning. Now, the reason they do that is because we all know that people have good days and bad days, and what differentiates depression from kind of normal fluctuations is this length of time, but also all these other symptoms and the severity. So it has to be a change, and at least one of these symptoms has to be either depressed mood or loss of interest and pleasure. So I highlighted the loss of interest and pleasure because a lot of older folks don't actually endorse feeling sad or down or depressed. They instead endorse feeling boredom or just having less pleasure in things that they used to enjoy. So they have to have 1 or 2 of these symptoms for the most of the time for a 2-week period, in addition to some of these other symptoms. So people with depression will often have weight changes. So they might either overeat or undereat. They might oversleep or undersleep. They may also have a lot of excessive energy. So the psychomotor agitation or retardation means like either kind of extreme restlessness, can't sit down, or just kind of feeling so slowed down that you actually can see a physical change in how these people kind of interact. And then fatigue or loss of energy, feelings of worthlessness or inappropriate guilt, as well as the diminished ability to kind of think or concentrate. and recurrent thoughts of death. So this could be either just going to bed and wishing you wouldn't wake up in the morning, or actually thinking of ways to end your life. So as you may have noticed on the last slide, there's a lot of overlapping symptoms between depression and those of Parkinson's disease. And so it can be kind of difficult to tease out what's actually going on and which of these symptoms are due to Parkinson's disease and which of these are due to depression. So for example, the psychomotor slowing that I talked about with major depression could also be bradykinesia, or kind of the slowing that we see with Parkinson's disease, kind of the restricted affect that we see in people who are depressed. So affect meaning kind of their facial expressions, and whether they're happy or whether they kind of have a range of facial expressions is often affected in people with Parkinson's disease who have reduced facial expression. Particularly people over the age of 60 who have depression have a lot of focus on physical illness. So they might have a lot of difficulties with GI symptoms and more pain. But a lot of times these kind of somatic symptoms can occur with people with Parkinson's disease. And then the vegetative symptoms that we see with depression, such as the sleep changes, the appetite changes, the fatigue, those also can go along with Parkinson's disease, as well as kind of the cognitive complaints that people have with depression and in Parkinson's disease. To add to that, a lot of the symptoms of Parkinson's disease are associated with an increased risk of depression. So different studies have variable results in Parkinson's disease, but all of these symptoms have been associated with an increased risk of depression in at least one study. So autonomic symptoms, motor fluctuations, the severity and frequency of motor symptoms, and then also age of onset. So like earlier age of diagnosis of Parkinson's disease and a longer course of illness have all been associated with an increased risk of developing depression. On the other side, depression and anxiety can often worsen Parkinson's disease symptoms. So we'll see worsening motor symptoms, more gait disruption, more freezing episodes, more on and off fluctuations, the cognitive difficulties, as well as an overall decreased quality of life. So you'll see people that there's a vicious cycle where people with increasing motor symptoms are at higher risk to develop more depressive symptoms. People with more depression have worsening motor symptoms, and so on and so forth. It's important to recognize that people who initially receive a diagnosis of Parkinson's disease may have a grief reaction. However, depression and anxiety could also be one of the first symptoms that they have. So it can be a herald symptom where people develop depression and anxiety when they have no history of psychiatric issues before, and those can happen in the 3 to 5 years leading up to the onset of motor symptoms. So aside from kind of the grief reaction of having this diagnosis, we also see a high prevalence rate for depression and Parkinson's disease. And in fact, it's a lot higher rates of depression than in other chronic medical illnesses. So 26 to 65%. Now that's a huge range, but it also may have to relate to the severity. So some studies included minor depression, some only major depression. And so you're going to have a large range when you're looking at different diagnoses and severities of depression. So why is it that Parkinson's disease has a higher rate of depression than other chronic medical illnesses? Well, some theory is that Parkinson's disease affects 3 of the major neurotransmitters that are implicated in depression. So serotonin, norepinephrine, and dopamine are all chemicals in the brain that are involved in depression, in which antidepressants a lot of times target these specific chemicals, but we also see that those are affected in people with Parkinson's disease. So this is a little bit of a simplistic diagram, kind of looking at what those different neurochemicals do. So norepinephrine is involved in alertness and in energy. Dopamine is involved in attention and motivation, pleasure and reward. And then serotonin is more implicated in anxiety, so obsessions and compulsions. So there are several different treatment options for depression and Parkinson's disease, and among these are the antidepressants. Although it can be difficult to be with a patient when you or a loved one aren't feeling well, it's important to recognize that also that medications don't work any faster at higher doses and may result in more side effects. So going back into the antidepressants, most of the antidepressants have been shown to be safe and well tolerated. And there's really not a lot of evidence that one class of antidepressants works better than the other classes of antidepressants. So again, we talked about how different antidepressant groups kind of target different neurochemicals. So like the SSRIs, like the Zolofts and the Prozacs affect serotonin. The SNRIs, such as Cymbalta or affect both norepinephrine and serotonin. And then medications like Wellbutrin target Wellbutrin or target dopamine. So really no evidence that one of those groups is better than the other. There's a little bit of evidence that nortriptyline may be a little bit more effective, but this is offset by the fact that nortriptyline is an older antidepressant. It's a tricyclic, and the reason that we don't use it as much is because of all the side effects. So it can cause a lot of dry mouth and constipation. It can also cause people to feel lightheaded when they stand up. So all of these things are things that people with Parkinson's disease are already fighting. And so we often don't want to give them a medication that makes these things worse. So what we often will do is we'll choose an antidepressant based on side effects. So for example, if a patient has difficulties getting to sleep at night and they're losing weight, they don't have a good appetite, we might choose a medication that has, sedation and appetite stimulation as a side effect. On the other hand, if somebody's having more issues with sedation, we're obviously going to maybe choose a medication that's more stimulating and that's less sedating. And again, kind of as I talked about earlier, it can take 12 weeks to see the full antidepressant effect. And so I think it is hard to be patient, but just knowing that it does take time and that if we push the dose too high too fast, we can actually have more side effects and not have it work any faster. So other treatments for depression and Parkinson's disease. So dopamine agonists. So these will be like the ropinirole or Requip or the pramipexole or Mirapex. So they've had kind of mixed results. There was a study that pramipexole reduced depressive symptoms over 12 weeks, but other studies have been inconclusive. One of the key things is looking at the characteristics of a person's depression. So if you notice that maybe you're only depressed during off times of your Parkinson's medication regimen, then maybe neurology needs to adjust the Parkinson regimen, and that might actually improve your depression as well as your motor symptoms. And then therapy. So there's a lot of different modalities of therapy, and compared to the general depression population, this hasn't been studied quite as much in Parkinson's disease. However, CBT or cognitive behavioral therapy has been shown to be effective for depression in people diagnosed with Parkinson's disease. And this is different than what people usually think of as therapy. Instead of kind of lying on the couch and talking about our childhood, this type of therapy tends to focus on a here and now approach. So, and it's kind of focusing more on the interplay of how people think and how they feel. So people with depression often have common negative thought distortions or thought patterns. So an example would be, I didn't do the dishes today, I can't do anything. So kind of this overgeneralization. And what's been observed is that these kind of negative thought patterns then lead to a worsening mood symptoms. So the therapy tends to focus on recognizing these thought patterns and then kind of trying to counteract them. And this has been shown to lead to an overall improvement in mood. And in one study, the people saw improvement in depression in this view of 10 sessions. So other treatments for depression and Parkinson's disease would be omega-3 fatty acids. There was at least one study that showed that maybe EPH was found to have a little bit more benefit. Dance has actually been associated with improved motor functioning, disease severity, depression, and social participation. And then exercise. So we know exercise is important for cognition and in mood. And at least one study looked at this in Parkinson's disease and saw that depression improved with exercise, that the group format of exercising together may lead to even more benefit than exercising alone, but all exercise is considered good. So apathy is another both symptom and syndrome that is common in Parkinson's disease. And it's characterized kind of by a general indifference or a lack of motivation and a lack of concern. Apathy is a little different from depression in that it can be both a symptom, but its own syndrome. And because it's characterized a little different, it has not been officially added to that DSM, the big book that psychiatrists use. That being said, researchers have still defined it, and they've kind of used it, defined it based on the following criteria. So basically having 3 or more of the following symptoms for most of a period of 4 weeks. And a lot of these are, you'll see, are decreased. So reduced initiative, so reduced self-generated activities or interests, less ideas, less curiosity, difficulty in maintaining self-initiated purposeful behavior. So this would be like difficulties in kind of maintaining hygiene, taking a shower, difficulty engaging in cognitively demanding situations. So this would be, people giving up very easily if they're kind of pushed to actually have to think through or problem solve. Blunted affect or emotional indifference, and just a generalized like reduced emotional response to both positive and negative events. People will see a reduction in affectionate behavior and just an overall lack of concern about personal problems. So is it apathy or depression? So in this slide, you can kind of see the overlap, and you can see that there's a number of symptoms that are common to both depression and apathy. But what you'll notice is that the depression part of the slide tends to have a lot more negative symptoms. So feelings of guilt, hopelessness, helplessness, pessimism, self-criticism, anxiety. So they're distraught and they're feeling this lack of emotion and lack of enjoyment, but they're also feeling really bad about it. Versus apathy is kind of a lack of concern and just an indifference to it. And that can have a big impact as far as treatment implications. So apathy is extremely common in Parkinson's disease. In fact, it's seen in 20 to 36% of newly diagnosed patients with Parkinson's disease. It does tend to decrease once dopamine medications are started for like motor symptoms, but it also tends to progress the more years a person deals with Parkinson's disease. So it can be up to 40% in patients after 5 to 10 years of Parkinson's disease, and up to 60% of patients with dementia of Parkinson's disease. So apathy that's not part of depression also is interesting in the sense that people actually might get pleasure out of activities. They just have lost their ability to anticipate pleasure. So you can see that leading to a lack of motivation. If you don't think something's going to be fun, you're not going to want to go there. That's different than actually going there and not having fun. So treatment. And this is kind of where, again, that distinguishment between is this apathy part of depression or not comes into play. So unless apathy is actually part of a depressive syndrome, there's no evidence that antidepressants help. In fact, antidepressants can sometimes worsen apathy. And we see this all the time with our antidepressants, where people just feel like they have less emotional range, and that can be very uncomfortable. It tends to be a dose-dependent effect. So we certainly, if you don't have elements of depression, don't want to be using an antidepressant that could make the apathy worse. And acetylcholinesterase inhibitors, which are considered cognitive enhancers. So these would be like the Ariceps or donepezils or the Exelons and rivastigmines. These work by increasing a chemical in the brain called acetylcholine. And this actually can help with apathy, at least in some studies, and people noted improvement after 6 months of treatment. Now, whether this corresponds with a higher rate of apathy in people with dementia, there may be a connection there. And then sometimes we will consider stimulants and weight promoting agents. So these would be medications like methylphenidate or Ritalin or modafinil or Provigil. And this has been shown to improve apathy in Parkinson's disease. It's a little bit more studied in things like Alzheimer's disease. And it's certainly not the most benign option. So I tend to kind of start with the first two and then move to this, mainly because these have some cardiovascular risks and also have some risk of possibly increasing visual hallucinations, which if somebody's already struggling with visual hallucinations, we certainly don't want to make that worse. So what can you do? So behavioral activation, this is basically a fancy term in my mind that means fake it till you make it. So research has shown that people who continue to engage in their usual routine are more likely to have depression improve than those who would kind of withdraw. And so it can be extremely hard to convince somebody to kind of continue to do this. And it may take everything you've got to kind of continue with your usual routine, but knowing that you might actually get better faster, hopefully, is a motivation. And this is often incorporated in cognitive behavioral therapy. So we talked about the cognitive part of cognitive behavioral therapy, where we talked about thoughts and the link with emotions. But the B, or the behavioral part of cognitive behavioral therapy, focuses on behavior, and that includes behavioral activation and how behaviors or changes in behaviors can improve or worsen mood. So kind of establishing a routine and continue to participate in activities. A wise coworker of mine once said, nobody gets better laying in bed, and this is particularly true with people struggling with depression. And then also because apathy, if it's not related to depression, is more of a lack of anticipatory pleasure, maybe scheduling pleasurable activities so that once people go there, they actually might enjoy it. It's just more of a motivational issue. And kind of on that point, increasing socialization. So we know that socialization is important for brain health, for cognitive stimulation, but also it can be very helpful for depression. So one of the goals of this talk was on communication, and this slide in particular is more directed towards caregivers. And this information actually comes from NAMI, which is the National Alliance of Mental Illness. And they have a free kind of PDF on their website on kind of how to discuss difficult situations and difficult behaviors with loved ones. And so, you know, one of the big topics they focus on is communication and empathy. And I think it's important for everyone to be heard. It's important to listen and to be empathetic to a person's experience. It's also important to recognize that everybody has their own perspective. And even though it might be different than ours, it's important to kind of validate their perspective. And this can be particularly important for people who have maybe feeling a loss of control over their lives. So if you're trying to encourage a person, like say you're trying to get them involved in behavioral activation, you could start by talking to the person and trying to come up with a shared goal, and listening to their ideas and sharing your own and kind of starting a dialogue. With apathy in particular, can be more distressing to family members and caregivers than the person themselves. And so recognizing and accepting that this may not be intentional, that they may have no more control over their lack of engagement and their withdrawal than they do over some of their motor symptoms. It's also important to have empathy and compassion for yourself. Caregiving is extremely stressful. And it's important to recognize that outcomes are not necessarily reflective of your efforts. So you could try very hard, and a person's course may just be different than another person's course. So it can be really helpful to consider a support group, both for the person struggling with Parkinson's disease, but also their caregiver. So it's amazing how many great ideas and strategies can come, not from doctors, but from other people who are down in the trenches kind of dealing with the similar issues. And then here's some kind of basic communication strategies. So if we've spent years kind of communicating with a loved one in a specific way, this can be a little bit challenging to kind of recognize that we need to stop and change our ways of communication. Particularly is important in people who might have some cognitive issues, but also with depression, because we know that they might have kind of slower processing problems and difficulty with attention. And so if we're kind of rambling on like I am now, it can kind of, we can lose information. It's important to kind of use short, clear, and direct sentences and to kind of keep the content simple. It's also good to recognize that if you want to talk about something important, like say an appointment time, that we need to kind of reduce the distractions. So turning off the TV, facing somebody directly so that they're able to kind of hear what you're saying and kind of integrate it a little bit more. If you're working with them on kind of behavioral activation, you may want to give a few choices, but you also may want to give less outs. So if you want somebody to take a shower that day, do you want to take a shower this morning or this afternoon? But you don't say, do you want to take a shower? It's going to be, more directed than that. If you want to have a heavy discussion or a difficult discussion, you may want to recognize that the other person may not be there yet and reapproach them at a different time. And then also kind of focusing on I statements. So this is important because it can change it from a blaming to more of a focusing on fact. So if you're concerned because your loved one is laying in bed all day, rather than saying, gosh, you're laying in bed all the time, you're not doing anything. You could be like, I'm worried that you're sleeping too much and that this is a sign that something's not right. And just as important as communicating with your loved one is also communicating with the healthcare provider. So this is part of the healthcare team, and it's good to be open and honest with your concerns. So in preparation for a visit, say you want to bring up depression with your healthcare provider, think about some things before you go in. So it might be helpful to write down some of these things so that it's there and you've got your list and you've set your agenda on what you want to discuss. So some things to kind of think about is your depression and anxiety worse at any particular time of day? Does anything make it better or worse? Is there any correlation between your on and off times of your Parkinson's medications in your mood? And then do you have concerns about treatment options? There's more treatment options for depression than just antidepressants. And if your provider brings up an antidepressant and you're not ready to go there yet, it's important to communicate that, because there may be other options on how to treat this. And we want you to move forward. The worst thing that you can do is to say, oh yeah, I'll take the medication, go home and not do it, and then end up in the exact same spot 6 months later when you go back to see your doctor or your healthcare provider. And then caregivers, it's really important to communicate your perspective. We really value it, and you may pick up on things that the person isn't recognizing in themselves. Well, ideally, this would be an open dialogue, and you would talk about your concerns in front of the person that you're caretaking for, as well as the doctor. But if you don't feel comfortable communicating in front of the loved one, then request to talk to the doctor alone. It's important to recognize that HIPAA, doctors may not be able to always communicate healthcare information, but you as a caregiver can always provide information to the doctor. And it's also important to communicate to your healthcare provider if you're feeling overwhelmed as a caregiver and if you need more support. So in summary, both depression and apathy are extremely prevalent in Parkinson's disease. Depressive symptoms include kind of a lack of enjoyment, but also a negative self-view, whereas apathy is more characterized by indifference and a lack of motivation and lack of concern. Depressive symptoms can worsen motor functions, and most antidepressant classes have been found to be safe and well tolerated, and no class is particularly more effective than others. But it's important to be aware that SSRIs can worsen apathy, while cognitive enhancers may help, and that the treatment of depression has been shown to improve physical disability and quality of life. So with that, we'll take any questions at the end of all of our presentations today. Thank you.
Hi, I'm Kara Iyengar. I'm the Center of Excellence Coordinator here at the University of Iowa Parkinson's Foundation Center of Excellence. I'm here today with John Weiss, who is a patient, a research participant, and a member of our PAIR group, which is a pilot project funded by the Parkinson's Foundation. PAIR stands for Patient Advisors in Research. This group is a group of patients who are interested in research. The purpose is to get more involved directly with researchers here at the University of Iowa, and also to design and conduct a study of their own. John will be talking mostly about his experiences as a research participant and a little bit about his experiences in PAIR. So welcome, John. Would you like to tell us a little bit about yourself?
Hi, Kara. Thanks for having me. Yeah, I'm 56-year-old person with Parkinson's. I've recently retired from engineering position at John Deere Tractor Engineering in Waterloo. I, with my free time, participate in some clinical trials in the pair group. I also like auto restoration, do some crew rowing. I like dancing and music, and time with family and friends.
Great. So John, what made you interested in participating in research?
After my Parkinson's diagnosis, I became interested in contributing toward the better diagnosis and treatment of the disease, and was interested in learning more about it and how I could impact it and how I could best manage it in my life. And participating in the research seemed like an avenue to benefit those things.
Great. What was the first research study you participated in?
Probably in 2017, I participated in a study at the University of Iowa with an EEG measuring brain waves of people with Parkinson's.
And what was that experience like?
It was good. It gave me exposure to the process of informed consent and exclusion and inclusion criteria. And then as far as the study itself, it involved sensors on the scalp to measure brain waves and taking a series of mostly cognitive tests, I think a little bit of motor tests also. And yeah, it was fine.
Great. How many studies have you participated in?
I believe 4 completed now, and I've got 2 more planned for 2022.
What's the furthest you have traveled to participate in research?
Definitely the furthest I traveled was last summer, 2021, where I was able to participate in a study with the University of Texas at San Antonio. So I made a quick trip to San Antonio. I got late notice about my inclusion. I'd found out late in the study about its existence, and for my fortune, a participant in Hawaii got excluded out, and they had an opening in the last minute. So I took advantage of it. I was very interested because the study involved a drug that promoted to help slow progression and maybe reverse progression of the disease, and involved biomarker measuring via spinal fluid, which I am interested in biomarker development.
Great. Why do you think it's important for Parkinson's patients to participate in research if they can?
I guess I'll give you my perspective personally, and I guess overall, I find it's important to me to contribute and have some influence, if possible, over the knowledge base for the treatment of the disease and the diagnosis. In general, because of the lack of biomarkers for Parkinson's, I think it's important for people to participate, to provide their feedback on what the safety and efficacy of the treatments is toward their symptoms and overall well-being. That there's only a small percent of the population with Parkinson's disease, and so we're pretty valuable toward learning more.
Okay. What has been the most rewarding part of participating in research?
Probably the satisfaction from just knowing you contribute to the development of better treatments, and in some cases, I've been able to continue the treatment in an open label status. So that's when I feel that's good for me, I've done that. And being able to interact with a variety of researchers and get different perspectives has helped me expand my knowledge and ability to consider how to get involved.
Okay. So kind of some benefits to you directly, and hopefully some benefits to people in the future. Yeah.
Yep.
So it sounds like overall it's been very rewarding to you, but what has been the most frustrating part of being a research participant?
Probably a lack of feedback of the results from the research. am very interested in what's learned, even in a blinded study. I think there'd be ways for the clinics administering the study to provide some feedback or notification when publications are available. That would, that's been an area of frustration. And I've gotten the sense in some cases where clinics are administering a study with a drug company that maybe the clinics are in it for their financial benefit to their clinic and not as interested in their research development. So that's not been with the University of Iowa. So one other place I participated with.
That does sound really frustrating. What do you think, what do you as a patient think that researchers need to know?
Probably the main thing, I guess, is to keep an occasional review of the perspective of the people with Parkinson's and what their experience is. They've been told that 20 years before they're diagnosed, their dopamine producing brain cells started degrading and dying, and now 70% of them are gone. And you're going to have complications. The degradation continues, and there's a sense of urgency with the population that I think I hope researchers are aware of to the individuals. And I guess I would encourage them to just stay abreast of the latest developments in the world and prioritize their efforts and resources toward those with the highest potential. And yeah, look outside and local with their patients as far as how to best direct and participate in studies.
Okay. And related to that, how can researchers better support participants?
Solid scheduling with as much time in advance as possible, especially for people that may need help traveling to studies. As far as traveling, reimbursement for travel is very helpful, especially with fuel costs going up now, and many people have to arrange for a driver. Those are some of the main things. And flexibility with scheduling is have a schedule in advance and maybe have a backup plan in case things would conflict at short notice.
Yeah, that makes sense. As far as Parkinson's disease research, what would you like to see research focus on?
Some of my main areas are identification of biomarkers. I think that's really key. That's been really helpful in advancing cancer treatments. If we could diagnose the disease in the first 20 years before we get motor symptoms, it may help address things earlier. So biomarkers, I think there's a lot of opportunity in levodopa management. I'm participating in a study of continuous levodopa delivery that I think has a lot of potential, and I've seen some benefit from. And just the overall electrical stimulation, deep brain stimulation, external stimulations, and closed loop systems for that to optimize them. And any closed loop for levodopa management would be great also.
Great. Okay. And what interests you in joining the PAIR project? That was the project I mentioned at the beginning of the talk.
Some of the same things that interested me in the research participation, but in addition to that, getting some exposure and interaction with people with the University of Iowa and Parkinson's Foundation that I would never have a chance to interact with really otherwise, as well as other patients, and hearing their experiences and different treatments and different experiences they've had, and getting their ideas as far as how to better partner between patients and the research teams.
Okay. And so you kind of answered this question, what has the experience been like? What have you liked about participating in that? What has been, since it's a pilot project, we're all kind of learning what has been some of the challenges or unexpected things?
The unexpected thing was that we were having to come up with encouraged to come up with a research project, which fortunately to one of the other team members, people with Parkinson's other than me, had a great idea. And the more we discussed it, the more we thought it was something that had a scope that we as lay people could contribute toward. And so, yeah, that was the unexpected thing. The other thing is it probably hasn't been as much interaction between the research team and the people with Parkinson's as far as the overall scope of the university's research strategies and priorities and how they work with the overall worldwide knowledge base. I'd be interested in having more discussions on that and maybe some input from our people with Parkinson's perspective.
Yeah, definitely. Is this a project that you would recommend people participate in as we wrap up the pilot and look towards maybe continuing in the future?
Yeah, I definitely would. It's been a good experience, even with the world of COVID. In some ways, that's made it easier, so we haven't had to travel. But I think it'd be good to. I look forward to be able to meet with people in person also. But it's not real difficult because of the development of technologies that, in some ways, COVID has provided. So you can participate that way without travel and without risk of exposure in the hospital that people may still be concerned about. And yeah, it's not real time consuming. We basically meet monthly and frequent enough to keep some momentum, but not so frequent that it's taken up too much of your time.
Yeah, that's good to hear. And so kind of in the last couple minutes here, would you encourage other people to get involved in research? And if so, what advice would you give someone who's considering getting involved?
I would definitely recommend getting involved as much as your schedule and capabilities allow. The recommendations, talk to your clinical team as far as studies that may line up with your specific challenges. I think if you can benefit from that it's good for them to know, and you would be fitting the intention of the study. And I guess make yourself aware beyond your clinical team of what's going on in the overall research world. Davis Phinney Foundation, Parkinson's Foundation, Martha J. Fox Foundation, and there's some other publications. Genetics and Biotech Engineering is one that I get weekly that about once a month I see some tidbit of advancement in Parkinson's research that has tipped me off to some opportunities.
That's wonderful. Anything else you'd like to add about your experiences participating in research-related projects?
Not too much. Just I think it's a great opportunity to contribute. One quote that I've always liked was that for those looking for milk, they shouldn't sit in the middle of a field waiting for a cow to back up to them. So it's an opportunity to get involved and influence your future and help others with the same challenges. So I'd highly recommend it.
Great. Well, thank you so much for sharing your experiences with us today. Again, this is John Weiss, patient and research participant. If you are interested in research, just as John said, reaching out to your clinical team or organizations like the Parkinson's Foundation is a great way to get involved. So thank you very much.
Thank you, Cara.